Good afternoon, everyone, and welcome to today's webinar on radiation hazards, to recognize the risk and develop a regional response plan with Angela Leek and Frank Reuter. Today's webinar objectives are listed on the screen. The webinar today is accredited for 1 continuing education hour for physicians, nurses, and EMS providers. Disclosure declaration. We have 1 disclosure today for our planning committee with Dr. James Lawler. If you have any questions throughout today's webinar, please use the Q&A section on Zoom, and we will facilitate a question and answer session at the end of the presentation. Here's the information to access your continuing education certificate. And with that, we'll give a brief introduction here of our presenters. Angela Leek is the Radiation Control Program Director for the Iowa Department of Public Health, where she is responsible for the licensing and inspection activities for all aspects of radiation producing machines and radioactive materials within Iowa. Angela has been involved in the radiation field for over 25 years and is certified by the American Board of Health Physics. She earned her master's degree in radiation health physics from Oregon State University and is currently working on her PhD at Iowa State University. Frank has a master's degree in radiation health physics and is certified in comprehensive health physics by the American Board of Health Physics. He's the director of radiation safety for the University of Nebraska Medical Center and Nebraska Medicine. He also serves as a radiation safety officer for the Nebraska Regional Radiation Health Center, and he serves as our Region 7 Radiation Specialty Team Lead. With that, Angela, I'll turn it over to you.
Great, thank you so much. We will get the screen shared here and start down the path. So thank you everyone for joining us. Frank and I have been working together over the past year or so in conjunction with the team here in Region 7 to hopefully provide information about radiation, emergency preparedness, and in relation to the annex that everyone is working on as a part of the deliverables this year to augment the plans that everyone has throughout their healthcare coalitions. So we look forward to giving you a little bit more information today. And we're trying to kind of work our way through the various concepts and information in hopefully bite-sized pieces that you can all take and integrate into your plans. So as we walk through today, I will recommend that you go back. We do have links to a website. I think it's being recertified for CEs as well, but it's about 3 2-hour sessions that go through some of the background of what we're going to talk about today. So I would recommend if you want to fill in some of those gaps and details, go back to those sessions. But always reach out and let us know if you have other questions or specific needs as we move our way through all this content. So again, welcome, and we'll go ahead and get started here, and we'll talk first about how to approach the radiation annex portion of the Healthcare Coalition plans. And why do we need radiation SMEs in radiation incident response? And the main reason is that radiation risk needs to be put into context. The plans and procedures that you have and many of the annexes that you've created already will be very applicable to a radiation incident. The piece that's different and the piece that requires a little bit of a context is radiation. And there's no single number that makes radiation good or bad or safe or unsafe. And so because of that, we need to be able to translate that and somehow make that applicable for whatever incident we're in. And Frank's going to talk a little bit about how incidents are different, and we're going to show some slides. And we want to try to give you guys a little bit of a concept on that. The other piece is that radiation exposure, even if you do get a very high dose, doesn't necessarily translate immediately into visible effects. There's a latent period, even for the very high doses, before symptoms manifest that might be visual or recognizable in a real clear manner. And the lower moderate doses often are just an increased probability of cancer induction as the main risk. Often radiation units are unfamiliar and they're not commonly used by responders or medical professionals or in the public. And so translating those terms into a meaningful fashion within your plan can be helpful as well. And it's easier sometimes to leverage radiation workers or others who do radiation work all the time and use these terms and concepts every day in a response or in your planning, rather than trying to do a bunch of training and try to remember terms or dose levels or limits that you may only use once in a very short span. So when I say radiation subject matter experts, who am I talking about? Who can actually help?
Hey, Angela, this
Yeah.
is Frank. I think some people are having trouble hearing you.
Oh, okay. I will see what I can do about that. I'm going to try to come closer to the computer. I don't know that there's much more that I can do other than that. Is it any better? Are you able to hear me?
I can hear you. It's a little weak.
Okay, sounds good. I will speak up.
Oh, that's better, Angela.
Okay, sounds good. I will project my voice as if I'm in a large room. Thank you so much for letting me know, though. I would hate to have gone through all the slides and had no one hear me, so thank you. Okay, so when we talk about radiation subject matter experts, and if you didn't hear very well on the first slide, fundamentally those things that are listed on the slide are the main reasons that it's a good idea to bring in people who work with radiation every day to help to translate and understand the radiation risk. So who are those radiation subject matter experts that you can bring in? And so we've talked about many of these throughout our sessions as we've done them throughout the past, but today we wanted to kind of show you a few that you could reach out to that are very likely in your local area where your healthcare coalition is, but they could also be at your state level, and we're also obviously going to reach into our region and to our federal assets as well. But the ones that I'm showing here and the ones that are very helpful for your local plan are those that are going to be there and available in the first minutes or hours before the federal assets arrive. They're going to be the ones that'll be there to help provide some of that context and to help coordinate those assets when they do show up. So those people are radiation control program staff. There is a radiation control program in every state that's responsible for radiation protection, licensing, the same bio you heard about me. There's a person like that in every state, and they have a staff and usually a lot of expertise in radiation and all of those aspects. Hazmat teams are well trained as well. Civil support teams can provide some context and field survey support. And then you have hospital staff, even within the hospitals that you have. If you have a nuclear medicine department, radiation oncology, or a radiology department, that you have staff there who are very versed in speaking about radiation and radiation dose terms. The radiation specialty teams are available. We have one here in the region, and Frank will introduce that a little bit more. And we have a term that's a radiological operations support specialist. And on the next slide here, I'll kind of explain that. It is a typed position through the National Integration Integration Center. It's a NIMS type position that you can actually request through EMAC. And they are trained to help respond in all types of radiation incidents. So they could be a health physicist background, they could be a first responder background, but they've been trained to help connect the dots, provide context, and translate some of the radiation information. There are several ROS across the country. We're working our way trying to get more on the west side of the country, but you can see that the various FEMA regions have several ROS. I am one of those ROS here for Region 7, and we're working on growing that number. So if you're in Region 7, please reach out to me. I can try to connect you with either a ROS or another radiation specialist in your area to try to integrate, to help with your planning, to help with response if we would ever have one. But there are some if you're from other areas of the country in your regions, and I can also help you find out where those individuals are as well. We also have the radiation specialty team that is based there here in Region 7. And it consists of a small number of subject matter experts, but specific into medical management of radiological casualties and radiation health physics. And the radiation specialty response team here in Nebraska has 2 radiologists, 2 board certified health physicists, and a board certified medical physicist. And Frank, do you want to add anything more about the radiation specialty team here?
Well, what we're in the process of doing is making a mission ready package So not only our state can utilize it, but other states. And so what we'd like to do is try to develop radiation specialty teams, starting off in each of the other Region 7 states. And they'll probably be based out of primarily the university medical centers, in particular the Radiation Injury Treatment Network, which tend to be bigger cancer centers that have typically more resources. But there's some other places. Iowa State, for example, has quite a bit of radioactive research, so they have health physicists. These are individuals that specialize in radiation safety. So this is what we envision on having these resources, and it's important to have a mission-ready package, just so anybody in the U.S. can utilize us, and in terms of liability and stuff, we need to have it. So that's kind of what our idea is.
Great, thanks, Frank. So when we talk about these individuals, so you identify who they are, you kind of bring them in. What can you expect that they're going to do for you? How can they help? So they are familiar and hopefully have been through some exercises and practices on emergency preparedness and or the application of radiation terminology and resources. And they can help to inform and connect you to radiological resources and help you know in your annex, here's the person you would be contacting if you had a radiation question. Here's the person who could provide you with data if you had these questions. They can also translate radiation terms and risks that are shown in products or information that's coming from a larger radiological team. So if we ever had a radiation incident, it's very likely we'd have a network of radiation professionals across the various aspects of the response. And so the state radiation expert could be plugging into the local support staff that is there, whether it's Ross or an internal staff person, and being able to bring that context. And we'll talk about that as we move forward just a little bit as well. We also can provide context on specific situations before a larger situational awareness might be established. So we don't know exactly the extent of the incident. We don't know exactly the type of isotope that's being involved, but they can give some context on the likelihood of an incident causing certain risks from radiation or certain aspects of radiation, as far as readings from a meter or types of response you're seeing from a patient or from individuals coming to a reception center. They can recommend or translate radiological response guidance. There's a slew of guidance, and if you've been on the ASPR draft annex template, you'll see that there are links to a multitude of websites that have links and resources and references, and they can help you to recommend which ones are good to include, which pieces of information you might want to specifically cite, and translate that into something that makes sense for your specific area and your response. And then they can help connect you to clinical reachback support to some of the federal assets like REACTS or other triage and treatment personnel who can help deal with contaminated or exposed individuals that you might be seeing. How do we integrate these radiation SMEs into a radiological response and the annex per se? So the first thing to do is to identify and connect with these state and local radiation program SMEs. So find out who in your state does the work for the radiation control program, or the emergency preparedness group may have a group of subject matter experts in radiation as well, maybe at Homeland Security or environmental protection. And find who those are. They are often in a position of recommendation making for a radiological response in your state or your local jurisdiction. And it's important to know what their plan looks like and how they would approach a response so that your healthcare coalition annex aligns with what you would expect. And states do that with the federal government too. We look at the Nuclear Radiological Incident Annex, and that shows how the federal agencies are all going to mobilize and respond to a radiological event. And so we try to align plans and our preparedness toward those models, because when the federal agencies come to help us, it's important for us to know how to best integrate to them as well. So I would recommend that at the local level, we do the same thing. We also can build capacity in-house. So if you're a hospital or a first response agency or public health agency, see if you have any in-house radiation expertise through a nuclear medicine technologist or through a medical physicist or other types of people who use radiation in and out, even if it's not for emergency response. And we can even try to hook them into the ROS program that helps to provide a lot more of that round context on radiation incident response, the incident command structure and things like that. Reach back to your regional resources. Frank and I are resources for all of you here as you're working through your annex and ongoing. But we are formed and are probably most accessible ongoing through the radiation specialty team we talked about, the ROS program. And then we also have our CSTs that are right here with us as well. And then we want to help coordinate that reach back through federal resources when we need those specialists from REACTS, or we have other types of assets that we're looking for. So a small scale event, your plans likely already say for a radiation incident to call some of these federal assets. But if we ever have a very large scale incident, we're going to overwhelm those resources very quickly. So it's going to be important that your annex, especially for the larger scale incidents, talks about coordinating with the state entity so that we can coordinate those resources and not deplete them more quickly than necessary. So how do we request radiological SMEs? And this is something that can be outlined in your annex. And state, county emergency management plans all right now include resources and references on how to request emergency management support or technical support. And that's the EMAC process. So it's the Emergency Mutual Aid Compact. And the allocation of radiation support, especially across state lines, is very similar in nature. So you can use those same plans and procedures to get that done. But it's important that you look for and or write in the actual people that you're going to be looking for, such as a ROS or a radiation specialty team. And if there are mission ready packages developed, include those into some of your documentation so that if you are looking for someone quickly because we find ourselves in an event, you're ready to go and ready to make those requests. Communication and common operating picture is critical. We will also share a lot of information through our normal plans that we share information now throughout COVID and monkeypox and all the things we're sharing now. Those same plans, those same pathways will be there for radiological events too. There might be some new ones. And there's a really important piece of tracking and keeping coordination of patient exposures and that type of information when they cross from potentially a reception center into a patient care setting and maybe back out for long-term tracking of what's occurred in this situation. So one of the big things that we'll go through here is how to look at the various aspects of what you do every day, what we should be looking at and considering from a radiological response, and how to inform that. And I'm going to turn it over to Frank to start with just a few basics and then some application to what you can do.
Okay, so are you going to take over this, Angela, or am I taking over?
I can continue to move slides if you'd like.
Oh, you can just go ahead and do it. Okay, we know that some of you are new to radiation, even though you have vast experience in emergency response, and then some of you have quite a bit of experience in radiation. So just to make sure we're all on the same page, we're going to do a very, very basic radiation primer on some of the principles. So then when we talk about some of the incidents and response to a radiation disaster, we have some idea what we're talking about. Next slide. So if you remember in our last webinar, we talked about the major radiological events. I just want to reiterate that the sessions that go into these much more thoroughly are now available, and they're located here at the website below. Let's go to the next slide. And the one thing you saw that they all have in common is they all involve the release typically of radioactive material. And just if you didn't know what is radioactive material, it's material that consists of atoms that are in an energetically unstable configuration is what they are. And they want to get to a stable energy configuration, so they need to get rid of energy. And the way they do it is through a process called radioactive decay. In radioactive decay, the major types of radiation emitted are alpha particles, which are helium nucleus, beta particles, which essentially are electrons, and gamma rays, which is electromagnetic invisible waves of energy. Next one. And when we talk about radiation, what we're talking about in radioactive decay is ionizing radiation. There's actually many different types of radiation. Microwaves. Think of radio waves, right? They're invisible. They consist of energy, and they can actually go through buildings and stuff like that. However, gamma rays and X-rays are energetically much more. A typical X-ray is a trillion times more energetic than a radio wave. And when they interact with our body, sometimes there's a process where they interact with the electrons in our around our nucleuses, and they can free the electron. And that process is called ionization. And this free electron can potentially cause biological damage if too much ionization occurs. Next. Just briefly about these particles, because you'll see them, for the next year. Like I said, alpha particles, they could be considered the bowling ball of the atomic world. They can't go they're very energetic, but they can't go anywhere without giving up all its energy. Consequently, you could stop it with a few inches of air, a piece of paper, or even the dead layer of your skin. However, and so if it's external, if it's outside our body, no big deal. But the problem is if it goes inside, then it can release all the energy in our body and cause quite a bit of ionization. For beta particles, like I said, they're like, it's like the pinball of atomic world. They're small electrons, fast speed, and they vary tremendously with energy. And so they can penetrate. Sometimes they can penetrate the dead layer of our skin. Sometimes they can't. They can be stopped by a few millimeters of tissue, and strictly and easily by aluminum or even plastic or lucite. And the gamma rays, just think gamma rays the same as X-rays. You cannot tell the difference between a gamma ray and X-ray. Actually, it's the only difference is how they originate. X-rays, gamma rays, as you know, are penetrating. The only way you can actually attenuate or kind of stop them is through lead or quite a bit of concrete. In most of the scenarios, these disaster scenarios that we're using, they'll have a lot of beta and gamma rays. And in particular, the gamma rays are the ones, the type of radiation that we can detect probably the easiest. And then also, they're the ones that contribute primarily to the dose of the victims or patients. Next. So how do these victims get exposed in these radiation events? And so what I put here, and this could be applicable to a dirty bomb or even a nuclear detonation. Go back one. And so you have this release of radioactive material, and it doesn't have to be. It could be particles. These particles could be in a gaseous state too. So keep that in mind. So you have this release of radioactive material spreading out. Okay, next. And so the three ways you get it, as you would maybe guess, is external exposure, external contamination, or internal contamination. Next one. So external exposure, usually that's the highest contributor to the victim's dose. It's from primarily the gamma rays from outside the body. So like when you have this plume, there's all these particles and they're giving off gamma rays, remember, like X-rays. So they're penetrating your body. But the patient does not become radioactive, just like when you get an X-ray. You know, you are receiving radiation, the radiation dose, but you are not becoming radioactive. So let's go to the next slide. External contamination. Now, external contamination, when we talk about contamination, what we're talking about is radioactive material on the exterior of the body. And that obviously could happen with a release of radioactive material. It's typically in the form of dust. A lot of it is going to be obviously on the patient's clothing. And we'll keep that in mind when we talk about decontamination. The dose that's emanating is typically pretty low, but while it's on the person, it's irradiating the person, and also it increases the possibility of the person getting inside, becoming internal contaminated, which is a lot more problematic on removing. When you're dealing with a contaminated, externally contaminated person, you just use standard precautions you do in the hospital to protect yourself. And that's really all you really need to do with these type of individuals. Okay, next. And as we indicated, in most of these scenarios where there's a massive release, a plume of radioactive material, and these individuals become externally contaminated, most of it is on the clothing. It's estimated that 85 to 90% of the external contamination can be removed just by removing the clothing. The remaining that's on the contamination that's on the body can easily, we usually typically use just lukewarm water and maybe a mild shampoo or something or soap to remove it. And if it isn't available, if you don't have water available, just by using dry decontamination methods, just using a cloth can actually be effective. Next. And then the final type of exposure is internal contamination. And as you would guess, you've got these particles and they get inside the body, either through inhalation, ingestion, or something like that. The radiation that's emanating from these people, even if they're gamma emitters, is typically quite low. Now, since they're internally contaminated, there's potential that their excreta, their urine, their blood could be contaminated. But once again, the radiation dose rates are going to be really low. And standard precautions are all what you need to do is try to prevent from being contaminated yourself. And in there's some situation, and as it indicates here, you can't be removed prior to treatment. Next one. So what kind of doses are we talking about? And it can vary quite a bit. In the United States, we tend to measure radiation dose, or sometimes people call it exposure. We measure it in units, or the smaller unit, a millirem, which is only 1,000th of a rem. Now you'll see a lot when you're starting to work with radiation, you'll see other units as well. Most other countries use the gray or sievert, and those are 100 times higher than a rem, but they're also a unit of radiation. So just to put things in perspective, a chest X-ray, which is a low amount of radiation, 2 millirem. A round trip flight from New York to LA, because of the higher cosmic radiation, less atmosphere protecting you, is 5 millirem. There's radiation, there always has been radioactivity in our environment, in the water we drink, the food we eat, in our bodies, in the soil. And for the average American, it's about 300 millirem a year. People like in Denver with higher mineral content and elevation, it's like 300 millirem. So say a millirem a day. CT with contrast is, now we're going to go to REM, a higher one. It's 2 REM or 2000 millirem. Radiation workers are allowed to receive 5 REM or 5,000 millirem a year. The risk they associate with that using a conservative model is comparable to safe industry, which is government office workers. And then for very, very high dose, you can potentially get into the acute radiation syndrome, or maybe you consider radiation sickness. But to get that, you need probably at least 100 REM or 100,000 millirem, and you need it also to be received typically by the whole body and within a short time period. And what we're talking about is either, within seconds or hours. Next. Just a few tidbits. If you don't know anything about radiation, we cannot detect when we are being exposed. We cannot neutralize radioactive contamination on us like we can with chemicals. So to decontaminate, we have to physically have it removed. And you typically can do that with water. However, there is a difference, another difference. Even though you're contaminated and we want to get it off so it quits, irradiating possibly the skin, and we don't want them to get internal contamination. It's not as urgent as chemical decon. I mean, if you have acid on your skin, you need to get it removed right away. With decontamination of radioactivity, you can kind of take your time a little more, and that's one helpful bit. Below 10 REM or 10,000 millirem, there's no way. We have no biological test to determine how much radiation exposure a person can receive. At higher doses, say greater than 75 REM, there are things we can use to kind of determine what, the radiation dose. Typically, the lymphocytes drop. The onset of vomiting is a good indication. Now we're talking about reaching radiation sickness. So we do have some biological dosimetry methods. Next. The other thing we just want to mention, at those high doses, which we're probably talking about 100 REM, probably 200 REM, they go through this acute radiation syndrome. They have a prodromal effect. That's the initial one that occurs typically within minutes or hours of exposure. You get nausea, diarrhea, anorexic, or something like that. Then they'll have a latent period, almost experience of well-being. I mean, there might be fatigue or something like that. That typically lasts days or weeks before the manifest illness takes place. And it may be, like I said, weeks to, potentially months. And then after that, they either recover or they don't. Below 200 REM, if someone gets it, you would probably just observe, and medical intervention may not be necessary. And above 200 REM treatment, if we do treatment, typically the treatment will be due to the loss of stem cells and various blood cells. And so you treat these patients similar to patients who have blood cancers. Now, we say this is what you should do. The treatment is obviously resource dependent on how many people you have, what you can and can't do. Next. So one thing, and I'm going to have Angela take over here, as we talk about the radiation events now, they're not all created equal. You'll see the magnitude can vary tremendously among different radiation events. However, the principles for your annex for dealing with radiation emergencies are all applicable. So let's keep that in mind. So Angela.
All right, thanks. And again, we're not going to go into all the various events, but we do want to show you some general ideas of what to expect as far as scope and scale. And we're using a reference to the Environmental Protection Agency's protective action guidance values. This is not indicating that people in this area would definitely need to be sheltered or evacuated. This is where projections would indicate that. And we're using this as a measure to put apples to apples. So when I show you some of these, when you look at the area, especially for a nuclear detonation, it is not necessary to evacuate that large of an area in the scope of that incident. And so again, I recommend that you go back and watch the videos that were on the link that we provided to put some of these into context, but we're not going to revisit the whole thing today. So this slide here is showing an example of a nuclear power plant scope and scale of where we might consider sheltering people in place or potentially evacuating. And so you can see this size, usually maybe to 10 miles, this might extend, and that's where the planning zone is. And if I put that in context with, actually the little circle's not going to show up apparently. So the little, hopefully you can see my cursor. There is a little blip right here. This is how big an RDD's respective version of a shelter in place would be, where I'm circling with my cursor. So if you put that into scale, if we have an RDD and we're using the same measure to decide whether we should evacuate or shelter a population, this is the size and scale. If it's a nuclear power plant, we're looking at this size and scale. And the next slide is showing us the nuclear power plant right here that we just looked at on the screen. And if we use that same measure for a nuclear detonation, you can see how much larger of an area we are encompassing. So you could expect to see the same types of dose rates, the same type of dose being seen under these shaded areas. But as you get closer into these various sites, we're going to be getting higher dose levels. And with a nuclear detonation is where we could really expect to see some of those more immediate, very high doses that might contribute to an acute radiation syndrome type of an exposure. But for the other two, the likelihood of an individual encountering that is low. And you can kind of see that circle there. So this puts the numbers to the pictures we just saw. And again, the likelihood of ARS individuals is possible, but unlikely for both an RDD and a nuclear power plant. And even if we had some, the numbers of those individuals would be in the handfuls to dozens. But for a nuclear detonation, we could have a lot of them, depending on whether there's fallout associated with the nuclear detonation or not. And the extent, as you can see, this just puts the numbers with it, of nuclear power plants about 40 times higher, and a nuclear detonation 150 times larger than an RDD. So while we are going to put some of the same principles in place, the way we are going to decon people, the way that we are going to treat people that have an exposure might have some similarities. There are some reasons and needs for us to make that a little bit different in the annex, and it can get a little bit convoluted. One of the other pieces is a timing distance. So this timing distance difference here is going to be demonstrated on this slide. And I'm going to play it here in a second. I'll probably play it twice. For a nuclear detonation, everything is being released all at once. And for a nuclear power plant, we have time and things maybe sputter and spurt over the release time. So I'm going to play this. And so if you're in a jurisdiction that has a nuclear power plant, a lot of the ways and the methodologies that we have in place to manage the response have this time kind of built in unknowingly. So if we try to apply those to the nuclear detonation, not only are we expending too many resources because our scope and scale is so much bigger, but we're also maybe not being responsive enough in communications and recommendations because or even managing individuals coming to our sites because they've been impacted immediately, and it's not something that's going to happen to them over the next 4 days, or, as what we kind of planned for a nuclear power plant. So I'll just kind of let this run. But you can see that there's a lot of decay that occurs with a nuclear detonation. So eventually, the comparable dose rates do shrink back and become comparable with each other, but that's months and years down the road. So we do need a couple of different postures. And these are just a couple of reasons why a plan for nuclear detonation needs to be different from nuclear power or other types of plans that might be in place. So I'm going to go back to Frank again.
Okay, thanks, Angela. So now that you have kind of just a very, very basic understanding, and once again, those videos are available and they go into much more detail than we did. We just wanted to try to put everyone on the same footing the best we could. Let's talk about an event occurring. So let's go. So you need to do this, right? Our biggest concern is probably contamination. The dose rate coming from these patients is probably pretty low. It's probably, say at a meter, it's probably definitely going to be less than 1 millirem an hour. But they're likely to be radioactively contaminated. So we want to don personnel, and this is what you would typically wear for a lot of situations where you're trying to avoid contamination. One thing I do want to stress is, even though we're dealing with radiation, don't wear a lead apron. They, first of all, they weigh like 15 to 30 pounds, and they were meant for very low energy scattered X-rays, diagnostic X-rays. Most of the radioactive material, the radiation will go right through them, so they're worthless. The other thing we'd like you, if you have the capability, is wear a dosimeter. A dosimeter just tracks your radiation exposure. Not everyone has to wear one. One could wear for the group. The one on the right is the one that typically a lot of people in your X-ray department, or if you have nuclear medicine or labs, they wear that. That's a dosimeter radiation badge. Those have to be turned in. It's good to have those because that can be a more official record. But the one on the left, that's a electronic digital dosimeter. And those are very useful just because you can go ahead and see what the radiation dose everyone's getting. And you can even put alarms on if it gets high. But it's typically, hopefully, to make sure the staff feels safe, if anything else. Okay, next. The other thing is, you're going to be having contaminated people come in. And so you need to try to control the amount of contamination. You need to create what they call an RCA, a radiologically controlled area. And you can, delineate it if you have stanchions or rope or tapes. It may just be a room. You may just say our ER is going to be our RCA. And if you go out, you need to take off, your PPE. And if you go in, you need to put in PPE. If you can, try to have a separate entrance and exit so we're not tracking. Everything in this RCA, you really need to assume is radioactive until you can survey it out. Next. Okay, what's really going to be important is how am I going to detect the radiation? The Geiger counter, the click, 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 if you're familiar with, that is very effective for measuring contamination and radiation, the presence of radiation. And it can give a rough estimate of the radiation dose rate as well. The one on the left, this is what you typically will find in a lot of nuclear medicine departments or university labs that use this. They're very, very, efficient and sensitive. The ones in the middle, I've seen these around our state emergency management agency. Used to give these out. These are old civil defense. They work. They're not near as efficient, but they can, measure radioactive contamination. And then the other one at the very end is portal monitors. And what these have are detectors in both vertical plastic pipes. These are great to have because you can just walk through and it immediately tells if the individual is contaminated or not. Next. So what are some other things you need to have in on hand? It's almost common sense. We need to have extra booties and PPE, not only for staff, but for patients arriving. It might be good to just have them put on booties as they're going to someplace to disrobe or something. As we indicated, if people are contaminated, we're going to want them to just, maybe the easiest thing might be just, if there's a lot of people, we need to get their clothes off. And so you're going to, keep in mind, you're going to have bags for their clothing and personal items, and you're going to maybe generate a lot of potentially contaminated waste in the decon and stuff like that. So you need to have lots of just bags, believe it or not. What are these patients, these victims going to change into? Whether it's a dry decon or, they have a shower or something like that. You're going to need to have towels, or you're just going to need to have something, scrubs or gowns would be perfect for it. Black plastic garbage bags, if worse came to worse. The decon supplies, it's very easy to decon, and we'll talk about that in a little bit. But squirt bottles, those are very effective for areas where the contamination is localized, and you'll want like those blue pads, medical blue pads, just so you don't have water all over the place. And then you're going to want to have the capability to collect blood and urine, and just Q-tips for nasal smears if there's potential of internal contamination. Next. So an event occurs. It's a dirty bomb, it's the nuclear blast, it's whatever. This is what you're supposed to do. You're supposed to get inside. And when we mean inside, we don't mean a car. Sometimes that's not effective at all. Get inside, stay inside, bring your pets inside if able to. You may need to turn off the air conditioning or something like that. And importantly, stay tuned so then your emergency management individuals can convey on what to do. They may tell you you're in an area you can evacuate safely or something like that. If there's a lot of, if it's a large scale event, the emergency management agencies will probably set up a community reception center where people who are not injured can go to determine if they're contaminated. We don't want them coming to the hospital and paralyzing our treatment of people who need medical treatment. Next. However, as we know, in a real situation, many people disregard this and they will flock to the hospital. So you'll have to be ready for this. So we'll go to the next slide. So you're going to have to triage patients, right? You've got a whole bunch. If it's life or limb threatening, you go ahead and you treat that patient, and you don't worry about decontamination or surveying or anything like that until they're stable. The radiation levels from these contaminated patients are likely to be very low. They're likely to be less than 1 millirem an hour. For the patients who are stable or we're in an area where they potentially could have received a very high radiation dose, what we're going to do is remove clothing and then proceed to survey and decontaminate. Now, how are you going to know where these people, in an area? That's where the SMEs can be very useful. And Angela, I think you were going to go ahead and maybe show a little.
Yeah, sure. So one of the things that the radiation SMEs that you can connect to, especially if they're plugged into the radiation emergency preparedness of the state or the local jurisdiction, or with the national response that's happening, is we have a lot of ways to make assumptions about radiation releases in an emergency. And so I'm going to bring over an image here. This is a system called CBurn Responder. It's a whole community solution for us to share radiological data. And so what I'm showing on the screen right now is a map from that system that can allow us to take in data points that maybe are being taken out in the field. And I'm going to caveat that this image is a drill image. It's from a tabletop that we did here in iOS. This is not a real incident. And so this is a way that radiological data from the field can be brought in. We can use it to create models. We can overlay models that may have been created for us. And so when you are being inundated by, people that are coming to your hospital, or you're being called to an area and you're not sure if you're driving into an affected area or not, we get these maps and we get these products really rapidly. And so these overlays that I'm showing are ways that we can show what's happening. And the radiological SME can help to translate these things, and they can put the maps up. They can take layers on and off to show things, which is what I'm doing at the moment. And we can be looking at what are the estimations of dose, what are the readings that we're seeing, and where might we have either contaminated people or impacts. So this really small blip right here is where we would have, remember when I talked about that evacuation and shelter recommendation area. From an RDD, this is that small little area, but we can have contamination, further. These are really, relatively low levels of contamination that people would be arriving with, but it would be detectable. And it might be some people that you might want to put in the line for survey and decon before people from other areas. So for example, if someone was arriving at your location, well, number one, you could decide whether or not your hospital was in an impacted area from this map, whether you would be seeing contamination or not. If your hospital was up over here, you're likely to not have gotten any contamination. So you do not maybe need to be a priority for a survey from the teams that might be working down here. The other things that you could do is ask people where they were. And so if they told you, because they're a worried well, that they came from the north side of town and drove on this street to get to you, then they did not traverse anywhere we would expect contamination to be. So you could ask them to wait and be the second in the wave of people to manage, versus someone that tells you they came from near the stadium or is being brought by an ambulance or something from this area. For the ambulance crews and others that might be going on scene, you can figure out ways to approach the scene where you're not driving right down the center of a contaminated area. And there's many things like that, like just this map alone right here, just to talk about contamination. A radiological SME can give you a lot of information in the first minutes and hours of a response that can help you know how to best manage this influx of people that you may have.
Okay.
I'll turn it back to you.
So you can see how useful the SME can be in turn, trying to determine who to triage or not. And as Angela said, if you get these worried well who come, who aren't injured or 5 miles upwind or something like that, they're just going to have to wait. Or you could possibly maybe have them do dry decon while they're waiting, or the possibility of just saying, if you want to get checked, you really need to go to a community reception center. In some scenarios, say it's a transportation scenario or something like that, you may be able to accommodate everyone who's involved. And in other ones, a dirty bomb or something like that, we're going to be overwhelmed. So you'll just have to triage. Next. Surveying a patient. The portal monitors are great. There's some good things and bad things. I mean, you go through, they detect a very small amount of radioactivity. What we use is a 1 microcurie, which is a very small radioactive source, 1 microcurie cesium-137, to see if it alarms. To put that in perspective, at a meter away, it's roughly about, I was just thinking, it's about 0.005 millirem per hour. So radiation is very, very small. And you think, well, why do we need to detect, that low? Well, we're not sure where it's on the person. And the other reason too is if they're contaminated, we do want to get it off them, because potentially it could get inside their body and lead to a higher dose. But it's great to sit there and say a go or no go, depending on what, how many people you have. The Geiger counters, the click, click, click survey meters, they are extremely sensitive, and they can be used obviously to pinpoint where the contamination is. Now, in terms of action level, you're going to have to check with your jurisdiction. It kind of varies, and in a big event, it may be changed, but they'll give you guidance as far as what's the when they are essentially clean or contaminated. As you would guess, in terms of order survey, you do wounds, then the orifices, in particular, your mouth and your nose, and then the intact skin is what you do at the end, with special emphasis on the hands and the bottoms of the feet, if anything. Next. How do I decontaminate? It's actually pretty simple. It's pretty standard. So wounds, you just do standard wound irrigation. We're typically going to be just using water, lukewarm water, to do this. If there's any foreign objects, we definitely want to remove those and also keep them for further analysis. Body orifices, have them blow their nose. Eye irrigation. We're not going to do any aggressive lavage. For intact skin, the skin is a great barrier. So we're not going to want to shave. We're not going to do aggressive scrubbing or anything that could potentially, affect this, barrier. Hair, gentle shampoo only, like baby shampoo, no conditioner. That just kind of puts it back in. So you're doing this. When do you stop decon? Now, mind you, too, on the decon, if the individual is ambulatory and fairly good shape, you could possibly have them do this at a sink or something like that with their hands, if you can pinpoint where the contamination is. Well, when do you stop? Well, if something happens, if their medical state, then and it needs the intervention, obviously you stop there. When you reach that action level, whatever it is for your state or local jurisdiction, then you can stop and say that they're clean. When decon would, you've just been doing it, it's not going down. If you do any more, all you're going to do is affect your barrier. And then the last one is, consult the SME if it's not coming down, because there's other methods of potentially decontaminating, from external contamination. Next. Just a few, this one thing I just wanted to put, you're going to want to document everything. If the patient comes in and they're vomiting, you want to definitely, note the time, because if it is very high radiation dose, that's a good indicator on what dose they received. Anything pertinent, patient history, obviously, any debridement, you want to keep all this stuff to determine potentially any internal contamination. If high exposure is suspected, or you don't have that many people, do a CBC with a differential. The drop in lymphocytes is a pretty good indicator on higher radiation doses. If you suspect there was internal contamination, one way would be you do the orifices are reading high, like in the mouth or nose. Just use Q-tips, wetting Q-tips, and do each nair, and then potentially a urine sample. Much of the internal contamination is excreted through the urine, and then contact the SME, and they can, direct you on where these can be sent. So then we can determine what the internal dose is and what countermeasures we may need to take. Next. Even after it's over, it's not over, right? What are you gonna do with the patients? Well, it just depends on your resources. You may want to admit them to the hospital, or they may be discharged, and give them instructions on what to look for. You need to send out those samples for analysis. You need to document and document and document. And then after it's over, you're going to have to survey and decontaminate the areas of use. you're going to have quite a bit of radiological waste. But it's, as long as you have it in a bag and stuff, it should be fine. And there's so many things that are associated with any type of disaster, but with a radiation event, there's bound to be some profound psychological fears and concerns. So you'll need to take that into account. Next. There is a ton of helpful material available on YouTube, Reacts, RITN, just REMM. And what we'll do is we'll maybe try to, Angela and I will try to maybe put a list on information that's very useful. This is from Reacts. I put that up. This is a nice logic tree on when a patient comes in, what you should do, and follow that. So next one, I guess we're done. I think we even made our hour. So with that, I guess we'll entertain questions.
Yeah, Frank, we just have a couple questions here. One question is, where would these radiological subject matter experts be located, or where should they be requested in an incident, such as the scene, emergency operations center, healthcare unified command, etc.?
Well, the way we look, we're a resource on these specialty teams. And in our state, for example, NEMA, Nebraska Emergency Management Agency, they're kind of our contact. And we would set up with a hospital. It may be through telehealth, it may be through Zoom, where we would also could physically, like if something happened, say in Council Bluffs, which is right across from Omaha, and Angela called and said we had a transportation accident. You guys are much closer than Des Moines and stuff. You know, we could go over there physically to provide assistance if necessary. So I don't know. I guess it's just on a case-by-case basis, I think.
And I'll add to that just a little bit. So for the radiation specialty team, definitely, you know, as Frank mentioned, firming up those mission ready packages, knowing where they're at. But subject matter experts exist in many places. So, you know, your state radiation control programs can be a person that you coordinate with all the time, or even your emergency management agencies that have a rep program or have radiological capacity. They're always willing to interact all the time with questions, with training, with any development of this annex, all of those types of things. And your staff at your hospitals and within your healthcare coalitions are also probably intermixed around and have some of this background as well. We're trying to create networks, trying to create ways that you can more easily kind of tap in, much like you do for a volunteer corps for other types of things when you need a cadre of nurses or a medical team for any other incident or an incident management team. We're hoping to have these radiation resources available in that capacity, and the ROS program is one of those ways that we're trying to do that. So I would recommend that you, in your annex, write that you will coordinate with your emergency management agency, which could be either local or state, depending on your jurisdiction, and make those requests or make those coordination points, and then they can ensure that all the right paperwork's in place to support the people that might be coming in person and to kind of facilitate any funding. And I saw that Deb Robinson made a comment about CSTs that they're requested through the state emergency management agency, and that all of that stuff is, and the same with the EMAC process, is to ensure that people have the right coverage for any work they're going to do, as well as you know, any support for where they're going to stay or what kind of resources they might need.
Perfect. Thank you, Angela. Another question here. Can you expand more on the mission ready packages? Is this personnel only or also equipment and supply?
Well, my understanding, and Angela, you might, I know Deb Robinson's on there. We are supposed to indicate what type of equipment that we can bring and stuff. So I imagine equipment can also be part of the mission ready package. Is that true, Angela?
Yeah, I think that it is. I think that it can be kind of a resource package. And even if it is people, it does include what the people are coming. Are the people coming with their own rad equipment, or do they need rad equipment? Are they coming with their own car, or will they need a car? Are they coming, with all those things? And so that's kind of how the states negotiate across the boundaries, or the jurisdictions negotiate to know who's coming with what. There are other ways to, I think, request resources, and it probably is through the EMAC process still. But yeah, I'm not entirely sure on that.
There's a couple of questions about the annex that you guys are working on developing to be shared. Are some of the graphs and other content presented here available in the template? And then also someone asked if there would be any fatality management inclusion in the annex.
Yeah, so I'll take that. So hopefully an email went out earlier today, at least to our healthcare coalition partners, and I think it can be distributed to this group as well. We created a little high-level checklist to kind of evaluate the HCCs and your resources, like how many survey equipment do you have, how many monitoring equipment do you have, how many radiation SMEs do you have, do you know where they're located, things like that. And then the annex has right now just a lot of comments specific to radiological. It's the ASPR template with some regional level for Region 7 comments in there. We can definitely work to, and I think these slides can be provided so you can integrate whatever makes sense for your plan. The next step beyond some of just the generic topics that we're bringing forward really will be dependent on what the annex is being tied to as far as your HCC plan. So if your plan includes certain reach back capabilities for a chemical incident, or you have burn capacity, or you don't have burn capacity, some of that's going to lead to how your radiation annex is going to look too, because you need to know your radiation resources, but you also need to know how you're planning to handle larger scale incidents as a whole anyway. So as every coalition starts to work on their annex, we'll help to fill in gaps, fill in blanks, but there's not going to be one kind of cookie cutter way to integrate some of this stuff, because it really will be dependent on your local jurisdiction.
Great, thanks, Angela. Looks like a couple more questions. Some came in the beginning, I think, and Frank, you answered them. The CDC has capacity to test patient and blood. Are there more commercial labs? What kind of tests may be required besides the CBC?
I can answer that one. In particular, for high radiation dose, there's a test. It's called a dicentric chromosomal assay, a DCA. It's the gold standard for determining what the radiation dose is. It takes a lot of expertise and time. It's not a quick test. There are several organizations. REACTS has one as a facility. We at University of Nebraska Medical Center, Nebraska Medicine has a facility. AFRI does, Yale. And in fact, what we're doing is Dr. Balaji, who's the director of the DCA lab, is putting together a consortium of these biodosimetry labs. And we just signed it this last week. And supposedly we're going to get funding from the DOE to ramp up the capabilities of doing this test. So that's probably the big one. There's a lot of other tests. I mean, besides, but the CBC is going to tell a lot. Not only the drop in lymphocytes, but also the neutrophil to lymphocyte ratio is also a good indicator of dose. Now, this is for very, very high radiation doses.
Great, thanks, Frank. Another question here. Is there any chance of getting a Ross course brought in from CTOS into Lincoln? We haven't been able to find enough folks to hold one here.
Yeah, I hope that there is. I'm actually teaching a Ross course this week in Albany, New York. So we hope that we will be able to get a course there. And CTOS is taking offers to host it. There's many offers in. There's many areas of the country that do want the Ross course. So definitely, as we coordinate, it would be great for us to offer to have it either in Lincoln or in Ames or Des Moines or somewhere in Kansas City, so we could bring all of our regional partners together. I think if we did that, we could definitely, there's no limitation to where the students come from, so we could definitely, I think, fill a course with our Midwestern partners.
Great, thanks. You just a lot of comments, good webinar, information on reaching out to EMAC and local EOC for additional resources, defining capabilities that you need in your mission ready packages. So I think with that, we will get the recording shared out in the slides along with the annex development tools that they worked on. So if anyone has any questions, please feel free to reach out to us. There's an updated code in the chat for your continuing education. And thanks, Angela and Frank.
Thank you.